My name is David Kissane and I'm a cancer psychiatrist from Australia, talking to you about our experience of legislated voluntary euthanasia laws in Australia, in the state of Victoria. Legislators have to really choose between two systems, the first of which will involve suffering that may be difficult to treat, and the second in which regulation of the assisted dying is difficult to perfectly enforce. In other words, one system supports the autonomy of the patient and the other seeks to protect the vulnerable. I want to suggest that there's widespread failure of safeguards and procedures across jurisdictions which permit euthanasia. Vulnerable people are therefore placed under a great deal of pressure when they have to make complex choices. As legislators, I suggest that your responsibility is to really protect the vulnerable, and that need outweighs that of giving autonomy to those who seek that. Here's a table which reviews the past 3 years of voluntary assisted dying permits being issued in the state of Victoria, Australia. And in the second row, you can see the number of patients who have self-administered their medication by mouth, year by year, increasing. You see a small percentage, about 15% of our cases involve physicians administering an injection, and a further proportion of people have VAD approved but don't take their medication. Our rate of VAD deaths is less than 0.1%, which is indicative of a high level of safeguards being present in the legislation. A thought of interest to you might be the clinical specialties of practitioners who have completed training and been approved to prescribe VAD in Victoria. A very small percentage of 0.6, mostly GPs and oncologists, with only 5 palliative care physicians taking an interest in this treatment format. I'm going to share with you 2 or 3 brief cases that have been de-identified. This first one is one in which family influence is pertinent. The partner emails the palliative care service to express concern about an adult child who's come back to Australia from overseas to say goodbye to their parent. And that adult child asks the parent if they'll proceed to take their medication now so that the offspring can be present. This causes concern to the partner, who's concerned about the patient's life being shortened, and hence the email is sent. When the physician who'd acted as the primary prescriber of the VAD went to review the patient, the physician asked the question of the patient, "Do you feel pressured?" And I would suggest to you that this is a rather naive question to ask of a parent who's going to deny feeling any pressure from their adult child. However, within a couple of days, the VAD medication was consumed, and in bereavement, the partner suffered and expressed some anger at what had occurred and felt that potentially some months had been removed from the patient's life. There's a very similar case written up in the Oregonian when the Oregon PAS laws were first introduced. I suggest that this is not an uncommon experience in which family pressure creates vulnerability in the sick person. A more positive case is a case of clinical depression, and here an oncologist identifies that cancer has progressed despite the recent anti-cancer therapy. The patient becomes distressed and inquired about VAD, so the oncologist made a referral to a cancer psychiatrist. The psychiatrist recognized that the patient had thoughts of giving up on their life, with a history of several weeks of feeling hopeless, fatigued, unhappy, with a loss of pleasure in life, such that life began to feel pointless and led the patient to think about thoughts of taking an overdose, which had persisted over a few weeks. The psychiatrist diagnosed a clinical depression, treated with antidepressants, and within a few days, the patient's wish to live returned, and several months of a fulfilling life followed. The oncologist went on to treat with alternative chemotherapy and immunotherapy agents, extending that patient's life. So it's a good story about appropriate treatment of depression, which may have led to the initial request for VAD. But VAD sometimes impacts on the quality of medical care, the quality of palliative care, and here's an illustration of a patient who had cancer-induced abdominal pain, and they asked their physician for VAD. The physician initiated the process of an application. The patient's pain was persisting, and they sought a second opinion from a different physician who rotated the pain-killing medication to methadone with good effect. The patient was surprised at this improved pain control and asked why the first physician had not managed them similarly. When the two physicians came to actually speak together about what had happened, the first physician acknowledged that once the VAD was requested, this had distracted the physician from attention to analgesics, and the physician acknowledged that they felt stressed by the VAD request, so that stopped trying to address the patient's pain-killing needs. This is an illustration, really, of how, for a group of physicians, a request for the VAD can start them down a process of forms, ticking boxes, and that procedure distracts from the quality of care provision, creates greater vulnerability in patients. One might ask why palliative care views physician-assisted suicide as incoherent with its practice. And here, to make sense of this, we can compare those that do separate palliative care and PAS from Belgium, where an integrated model is practiced. A patient can be admitted to a palliative care unit in Belgium for symptom control, and eventually they can be asked if they've thought about euthanasia. It can be economically advantageous to clear beds. One might wonder if a hospice becomes a dumping ground for euthanasia. Is the decision really autonomous when the patient's put in this predicament? Does it make palliative care futile in the way it's delivered? So the argument for separating palliative care from euthanasia is that palliation is never futile, that it's incoherent with the principles of good palliative care, and thus we avoid the risk of a patient feeling that they have a duty to die. The palliative care team maintain hope in the here and now and sustain quality of life until natural dying intervenes. This avoids any devaluation of palliative care and stops people fearful of palliative care being a place where euthanasia may be delivered. Much of the promotion of euthanasia has come about because of a country such as Canada, whose Supreme Court ruled that a ban on euthanasia interfered with their Charter of Rights and Freedoms, and so in 2016 Canada introduced a bill for medical assistance in dying, otherwise known as MAID. And initially their restrictions required that death be reasonably foreseeable. However, this clause was removed in 2021, and in March 2023 their legislation will allow the mentally ill to apply to receive MAID. One notes in Canada that 99% receive an injection as an anaesthetic procedure, with patients preferring to have an anaesthetist put them to sleep rather than taking medications by mouth that they have to self-administer. One notes the population of Canada nearly 40 million, and that MAID deaths are now affecting 2.5% of the people who die in Canada. Of interest to me as a psychiatrist is this survey of attitudes of psychiatrists in Canada to MAID, particularly in the context of it being provided to people with mental illness. And we see here that nearly 70% of psychiatrists opposed the use of MAID for mental illness. Their reasons for not supporting MAID included the prospect that it would change their commitment to a patient who had enduring suffering, change response in treatment to persistent symptoms that proved challenging to bring under control, and a recognition that psychiatrists had had prior patients who would have qualified for MAID, and yet these patients had recovered when their mental illness was treated. I'd like to draw your attention to this recent article published by the investigative journalist Alexandra Rakin in the New Atlantis in Washington in the US, which reviews the use of MAID in Canada, contrasts the high proportion of MAID deaths in Canada with California, a place of a similar population size, which has only 400 PAS deaths per annum. So we see that Canada has really become the most permissive country in the world. And a psychiatrist here at the Princess Margaret Cancer Centre, Dr. Madeline Lee, was initially supportive of MAID legislation and was responsible for undertaking psychiatric assessments. Subsequently has given recent evidence before a parliamentary committee that the legislated safeguards have become impotent in Canada, that they fail. Rakin's investigation showed a number of reasons for people seeking MAID, including financial debts, poor housing circumstances and other social issues, and the absence of available medical care as perceived by those patients. The change to removing the presence of a terminal status allows the inclusion of mental illness, and it seems likely that mental illness and loneliness are going to become key reasons for people pursuing MAID. So poverty and mental illness drive MAID in Canada, a very concerning state of affairs. So, as legislators, you'll be asked to consider, do you privilege autonomy or do you protect the vulnerable? Already in Victoria, after 3 years, campaigning's begun to relax the safeguards that were introduced here. When euthanasia is made law, that normalisation of killing occurs in society, and efforts that are initially restrictive to protect the vulnerable are challenged and safeguards are progressively eased, such that depressed and vulnerable people won't be protected and the quality of medical care may well decline. I want to suggest to you that this will create grave danger for the delivery of optimal palliative care, because it's so much easier to euthanize a person than it is to work to ameliorate their suffering. Doctors may lose their ability to instill hope and lift the morale of patients who are struggling with a number of existential themes. In my opinion, Britain has the best palliative care in the world, and I encourage you not to forfeit it, not to lose it, by bringing in legislation that permits euthanasia within your society.